Hello friends, welcome to yet another session on this immunization series, and this time we'll be talking something about rabies vaccination. Okay, this might be for quite a long duration because we'll have to talk on various aspects. Okay, and this is one of the most confusing thing to read as well because of the various schedules that is given and various guidelines that is given. So I've tried to simplify it as much as possible, and whatever we are going to read today is from the recent WHO guidelines, the recent National Rabies Control Program guidelines of 2019, or the and from the IAP guidelines. Okay, so these are the three guidelines which we'll be reading from. Okay, so coming to the introduction. Fine. First of all, what is the need for this vaccination? The most important need being, once we get any of the patient get rabies, it is uniformly fatal. Okay, it is uniformly fatal. So it is as well better to prevent the disease from occurring. Okay, that is the importance of this vaccination. So coming to the transmission, how is it transmitted? Okay, it is either from the bite of the animal, scratch of the animal, or lick of the animal on the mucous membrane or the non-intact skin. Okay, so this is how it is transmitted by the rabid animal. Okay, and it is very rarely from human to human transmission as well can occur, either from the secretions from a person who is suffering from rabies, so a very close contact with that, or from an organ or tissue transplantation. Okay, fine. Now what is the incubation period? So though the average incubation period is around 4 to 6 weeks, it can range from anywhere between 5 days to 6 years or longer. 6 years or longer is also possible. Okay, so that is the reason why there is no upper date for vaccination. So even if a patient has got rabies dog bite dog bite 5 years back, and he comes today to your clinic, but even now he will be a candidate for vaccination. Okay, so that is the importance of this. Okay, so there is no upper limit, so any time after a dog bite, vaccination can be given, though it has to be given as early as possible. Anytime during the course, if they come with the complaint of dog bite, please, we have to advise a vaccination. Okay, so the disease is uniformly fatal as already told. And coming to India, 96% of them who approach for rabies vaccination is because of dog bite. Okay, and approximately 40% of these cases occur in children. So there is a very high incidence in children less than 15 years, the amount of dog bite. Okay, and most of the cases of rabies occur in the developing nations of Asia and Africa. So looking at the burden, around 61,000 deaths occur yearly due to rabies, and most of them come from India, around 20,000 deaths. And why is this so? Because there are around 17 million animal bites, but there are only around 15 million who receive the post-exposure prophylaxis. So there is a huge margin of gap, correct? So that is why this huge burden in India. Okay, next let us see, when do we consider the post-exposure prophylaxis? So all we are going to talk about is how to prevent this rabies from occurring. How do we prevent? It is by giving the post-exposure prophylaxis. Okay, so as per our guidelines, as per our National Rabies Control Program guidelines, post-exposure prophylaxis for rabies has to be considered in bite by all the warm-blooded animals. Okay, including the pet bites, and including the pet bites even those pets who are vaccinated, because it is irrespective of the vaccination status, because we still don't know the response that an animal produces for the vaccination. So we don't know how a dog or a cat responds to the vaccination. We don't know whether there is uniform seroconversion in them or not. That is why even if the dog is vaccinated, even if the pet is vaccinated, still post-exposure prophylaxis is indicated. Okay, next, exposure to any wild animals. Exposure to all the wild animals should be treated as category 3 exposure. Now what about rodent bites? Not the domestic rodents, but from the forest areas. If there is a rodent bite, then again post exposure prophylaxis needs to be considered. Now coming to exposure to bat, according to the National Rabies Control Program, they do not warrant any post exposure prophylaxis, but as per the IAP textbook, post exposure prophylaxis needs to be considered. IAP as well as WHO recommends even for exposure to bat post exposure prophylaxis. And coming to human transmission, post exposure prophylaxis should be given in those who are exposed closely to secretions of patient suffering from rabies. Okay, fine. So these are the indications for post exposure prophylaxis. Next, let's see, in case there is a bite, let's say there is a dog bite. How do we go ahead and prevent this rabies from occurring? Is it just the post exposure prophylaxis? No, correct, there are certain steps. So the first step and the most important step, this is the most important step, this is the, after this comes the rabies post exposure prophylaxis or the rabies immunoglobulin. Okay, so the most important step in preventing rabies is the wound care, because just by wound care we can prevent around 60 to 70% chances of rabies occurring can be prevented just by the wound care. So that is the first step. Okay, so how do we do it? There has to be immediate wound care given. Okay, and even if the patient presents to us long after exposure also, it is the first step that has to be done is wound care. So it consists of minimum of 15 minutes. Okay, 15 minutes, more than 15 minutes of washing with soap and water is recommended. Following by that, disinfection is indicated. Okay, following this, there should be disinfection to be done. Okay, if there is bleeding at the wound site, okay, that indicates that there is potentially severe exposure, and this indicates that it is a category 3 wound exposure and probably an indication for rabies immunoglobulin. Okay, and other modalities for wound treatment include, after cleaning the wound thoroughly, we might have to consider antibiotic and tetanus prophylaxis. Okay, so when is this antibiotic prophylaxis indicated? According to the American Academy of Pediatrics, okay, so they, according to them, prophylactic therapy with antibiotics should be given for 3 to 5 days. Okay, 3 to 5 days, and best started within 12 to 24 hours after injury. If this is done, according to their study, it tells that there is some amount of preventive role in the there is some amount of prevention offered in the further wound infection happening. Okay, and what is the indication for this? Any moderate to severe wounds occurring on the face, hands, feet, or the genital area. Okay, or this bite involving any tendon, bone, or joints, and bite resulting in devitalization of the tissue. Okay, and all the immunocompromised children. Okay, so all these things are indication for prophylactic antibiotic therapy. Okay, and what is the antibiotic that can be used? They tell amoxicillin is recommended, but in case if the children is allergic to penicillin, then trimethoprim sulfamethoxazole plus clindamycin can be given as oral therapy. Okay, next, coming to tetanus prophylaxis, if the total tetanus immunization is not completed, that is less than 3 doses is given, or the child is immunocompromised, okay, or the status is not known, tetanus prophylaxis or toxoid status is not known, then both tetanus toxoid with tetanus immunoglobulin is indicated. Okay, but if the person has received more than 3 doses, he's completed his tetanus immunization schedule, then we go ahead and give the TT, presently given as TD, okay, In children with clean or minor wounds, if the children is having clean or minor wounds, okay, clean or minor wounds, if they have received their previous dose more than 10 years, there is a gap of more than 10 years, it is indicated. Okay, if all the other wounds, in case of all the other wounds, it is more than 5 years. Okay, more than 5 years, as simple as that. Okay, to repeat once again, if it is less than 3 doses, that is, he has not completed his course, or the status is not known, or is in an immunocompromised state, then TD along with tetanus immunoglobulin is given. Okay, if it is more than 3 doses, that is, is completed his schedule, then TD is indicated when, if it is clean or minor wound, then if the duration is for more than 10 years, it is indicated. If for all the other wounds, if the previous dose that is given is more than 5 years, then it is indicated. Okay, fine. So we are done with the first step, that is wound care. So, and the last thing is about suturing. So WHO and our guidelines also ask us to avoid suturing until and unless rabies immunoglobulin is infiltrated. But still, if we have to go ahead, in case rabies immunoglobulin is not available at that point of time and he is bleeding profusely, in that case we'll have to consider putting loose sutures. Once the rabies immunoglobulin is infiltrated, then to put a proper suture. Okay, fine. So that is about the wound care. Now, after giving proper wound care, we'll have to decide whether we'll have to give post-exposure prophylaxis and rabies immunoglobulin. So how do we decide on that? So before that, for that purpose, we'll have to categorize the wound, correct? So we'll categorize into 3 parts: category 1, category 2 and category 3. So what is category 1? Just touching or feeding animals or lick on intact skin. Okay, so this indicates that there is not much exposure. That is category 1. Now what is category 2? There is some amount of exposure. This will happen when there is nibbling of uncovered skin, or there are minor scratches, or there are abrasions. Okay, but there is no bleeding in any of these circumstances. That indicates that there is some amount of exposure. This is category 2. When do we tell there is severe exposure? When do we tell it is category 3? When there are any transdermal bites or scratches, okay, contamination of mucous membrane or broken skin with saliva from animal licks, okay, or exposure due to direct contact with bats. Okay, this last one is not present in our National Rabies Control Program, but it is present in WHO as well as IAP. Okay, fine. So this is how we categorize the wound. Then comes the next 2 steps. One is post-exposure prophylaxis and rabies immunoglobulin. So when are this indicated? In case of category 1 wound, only wound care is indicated. Okay, no prophylaxis is required. If it is category 2, then along with wound care, we need to give post-exposure prophylaxis. Now finally coming to category 3. Over here, wound care with post-exposure prophylaxis with rabies immunoglobulin is indicated. Okay, fine. So next we'll have to see how do we go ahead and give this post-exposure prophylaxis, correct? So post-exposure prophylaxis is given by vaccinating the child or person against this rabies. Okay, so what is the type of vaccine? Now we'll learn about the vaccine. Okay, so it is basically a cell culture vaccine. Okay, and 3 types are available. All the 3 types have the same efficacy. Okay, so one is purified chick embryo cell vaccine, purified vero cell rabies vaccine, and one more is purified duck embryo vaccine. All the 3 have the same potency and same efficacy. Okay, what should be the content? Minimum content of 2.5 international units per intramuscular dose. Okay, now what is the dose? Depending on the type of vaccine, for IM it is either 0.5 ml or 1 ml, and for intradermal vaccine it is uniformly 0.1 ml. Okay, it is stored at 2 to 8 degrees Celsius, and at this temperature it is stable for 3 years. Okay, and how is it available? It is available in a lyophilized form with the sterile water as diluent will be available. And once reconstituted, it has to be used within 6 hours. Okay, if it is reconstituted once, it has to be used within 6 hours. Okay, then coming to the site, intradermal or intramuscular. If it is intramuscular, if the child is more than 2 years, deltoid is indicated. Okay, if child is less than 2 years, anterolateral aspect of the thigh is indicated. Okay, fine. Coming to the efficacy, protective antibody develops in more than 99% of the vaccine recipients. Okay, so efficacy is very good. Duration is long-term immunity is present because it is capable of inciting our memory T cells. Adverse effect of following immunization is the same. Both local and systemic effects are present. Local effect includes pain, swelling and redness in the local area. Systemic includes fever, headache, dizziness and few GIT side effects. Okay, fine. So now we learnt about the vaccine. Next, let's see how do we go ahead and give this vaccine. So that is nothing but the post-exposure prophylaxis. This is the WHO recommendation and this is being presently followed all over the world. Okay, so as we already learned, category 1 exposure, just the wound cleaning is recommended. Okay, just the wound cleaning is recommended. What about category 2 exposure? Category 2 exposure, as we have learnt, is wound cleaning followed by post-exposure prophylaxis. Now this post-exposure prophylaxis we have already learnt can be given in as intramuscular or intradermal dose, correct? So what is the intradermal dose? For intradermal dose, this is the schedule that is being followed. Institute, Pasteur, Du, Cambridge. Okay, so according to this, it is given on day 0, day 3 and day 7. Okay, day 0, day 3 and day 7, and on each day 2 injections are given. Okay, day 0, day 3, day 7, 2 injections are given. Okay, now what about the IM? For intramuscular, the regimen that is followed is short SN regimen. Okay, short SN regimen. According to this, it is day 0, day 3, day 7, and the next one is between day 14 to 28, day 14 to 28. Okay, and one more regimen that is followed is that is recommended by WHO is Zagreb regimen. Okay, but as this is not recommended in our Indian schedule, we will not talk about this. So we either follow the Institute, Pasteur, Du, Cambridge or the short SN regimen. Category 3 is the same with the rabies immunoglobulin. Okay, now what about people who have already received this post-exposure prophylaxis or people who have received pre-exposure prophylaxis? In them, what do we do? It is the same for category 1 exposure. The change comes in category 2 and category 3. So if this pre-exposure prophylaxis, if the post-exposure prophylaxis is given within 3 months, less than 3 months, then further post-exposure prophylaxis is not indicated. At that time only wound care is important. Okay, wound care is important. But if it is more than 3 months, and it is category 2, that time wound washing along with vaccination is indicated. And the schedule that is followed is, if it is intradermal, on day 0 and day 3, okay, and only 1 injection is given as compared to 2 injection. Over here only 1 injection is given. Okay, this is the schedule that is followed. If it is IM, if it is intramuscular, then what do? We give the same day 0 and day 3, okay, and again single site. So there is not much difference between the intramuscular and intradermal regimen. Now same, but category 3, the schedule is the same, but the rabies immunoglobulin will not be indicated. Okay, as simple as that. This is the post-exposure prophylaxis indicated by WHO. Okay, what about other schedules? There are so many schedules that are present and confusing to us. We will just remember this basic schedule. Okay, one is the Institute Pasteur D Cambridge schedule, other one is the short SN regimen IM. Okay, so if we remember these two regimen, it is more than enough. What about the other schedules that is present? This is just to have a look at it. One more is the modified SN regimen IM, that is given on day 0, day 3, day 7, day 14, day 30. One more which used to be given before is Thai Red Cross regimen, and presently the updated Thai Cross regimen. Even this is not being indicated by WHO because of the newer schedule Institute Pasteur du Cambridge. Okay, so according to updated Thai Cross regimen, again it is given on 0, 3, 7, 30, and each of them comprises of 2 injections. Okay, fine. Now previously intramuscular used to be given, then came the intradermal. Why was this intradermal schedule introduced? Because it is cost effective alternative, because for intramuscular 0.5 or 1 ml needs to be given, as compared to intradermal wherein only 0.1 ml needs to be given. So this is obviously more cost effective for the government, correct? But we have also seen that once the vaccine gets reconstituted, it has to be used within 6 hours. So until and unless we get a whole lot of patients to a center, we cannot give intradermal because it will be of waste, because only 0.1 ml will be removed from 1 layer, correct? So intradermal is a cost effective alternative, but it is only indicated where there is in a center where there is good number of patients coming daily. So attendance of minimum of 50 patients per day should be present in that center for intradermal to be given. So what is the criteria for selection for this intradermal includes? One is, as told, minimum 50 patients per day. Second is adequately trained staff should be present. Third is a good cold chain maintenance should be present. Okay, fine. So this was about the post-exposure prophylaxis. This we read in detail. I hope there is no confusion. Okay. Next we will see about the passive immunization. This is about the rabies immunoglobulin. Now there has been a recent advance of monoclonal antibodies that is present. This is more effective as well as less amount of side effects are present. And the one that has already been existing is the rabies immunoglobulin. This can be taken from human as well as equine, correct? Fine. So first we'll read about the most recent one, that is human monoclonal antibody. This is called as the rabies shield. Okay, so it is the recombinant human IgG1, and this goes and binds to the G glycoprotein of the rabies virus. Okay, what is the dose that is indicated? 3.3 international units per kg. And what is the advantage? It has lesser side effects. Okay, and the dosage indicated as well as is less, 3.3 international units per kg. So even if the wound is small, a large whatever concentration of rabies immunization is required can be given into that smaller wound as compared to the rabies immunoglobulin, because the dosage is higher, correct? Okay, fine. So that is one more advantage. Next, coming to our immunoglobulin, which was being present from past. One is the human, second is the equine. Human is much more effective and it has much less side effects as compared to equine, so it is much more preferred as compared to the equine. Okay, so human dose is 20 units per kg with a maximum dose of 1500 international units. As compared to equine, it is higher, slightly higher, 40 units per kg and a maximum dose of 3000 international units. Okay, and next important point to be noted is we give vaccination on, like, patient gets a dog bite and he comes today, so you give the first day of vaccination. So this will be the 0 dose of vaccination. Okay, and actual indication is to give rabies immunoglobulin on that day itself, but there will come a situation wherein you don't have the stock of rabies immunoglobulin. Okay, so in such a situation the rabies immunoglobulin should be given before the 7th day. Why? after the 7th day this vaccine would have started acting. So there is no use even if we give the rabies immunoglobulin after 7 days. Okay, so that is the importance. So it should be given before the 7th day of the first vaccination. Okay, and what is the site? Now again there is a confusion regarding this, but as per WHO, infiltrate as much as possible into the wound. Okay, but even after infiltrating as much as possible, there is some amount left over, then just discard it. Okay, or give it, if it is still sterile, you use it to for the application to an other patient. Okay, so infiltrate as much as possible into the wound. That's all. That is the WHO recommendation. Okay, and in case only limited amount is available, okay, then we'll have to prioritize. Okay, we'll have to prioritize, and it should be given to patients with multiple bites, or the ones with deep wounds, or the ones with bites into highly innervated parts of the body, or the ones having severe immunodeficiency, or the biting animal is confirmed to have rabies. Okay, and there is exposure to bats. Okay, so this is the prioritization which you'll have to do in case there is limited amount available. And what are the side effects? As we already know, it is local side effects with hypersensitivity. Okay, fine. And what about certain special population like immunocompromised state? When it comes to immunocompromised state, the rabies immunoglobulin is indicated even in category 2. So that is the small change. Both category 2 as well as category 3 people will receive rabies immunoglobulin. Okay, and one more additional thing is anti-rabies antibody estimation has to be done 10 days after completion of the complete schedule to see whether there is seroconversion or not. Okay, so this was to do with the post exposure. First step was the wound care. We learnt about wound care. Second step was to categorize, then was to give the post exposure prophylaxis, then was to give the rabies immunoglobulin. Okay, so we have dealt with everything. We have dealt with all the three. So we have taken care of the wound and we know how to prevent it. Next, let's see and talk about pre-exposure prophylaxis. Pre-exposure prophylaxis. What about people who are continuously exposed to this rabies virus? In them, what to do? In them, how to prevent? So in them, in these high-risk group people, they are further divided into people with continuous exposure. These are lab persons who are working in research laboratories or the ones who are involved in the production of this rabies virus. Next is frequent exposures. These are veterinary people or any medical workers or forest or zookeepers. Okay, these are known as frequent exposures. And lastly, infrequent exposures. These include postmen, policemen, travelers into the endemic area, etc. These are infrequent exposure group. So the high risk groups have been divided into these three groups. Okay, and the rabies vaccination is indicated among them. Okay, now what is the schedule that is followed? In immunologically naive individuals, just 2 doses are given on day 0 and day 7. Okay, if it is intramuscular, just single site injection. If it is intradermal, then 2 doses are given on each day. Okay, in case of immunodeficiency, one more dose is given on day 21 or day 28 along with this. Okay, so as simple as that. And in case of continuous exposure people, in these people, antibody titer estimation is indicated every 6 months. Okay, so that we get to know whether the immunity is waning off or not. And if the antibody titer is less than 0.5 international units per ml, one more single booster dose is indicated among them. Okay, fine. And if this facility is not available in that particular region, okay, then the indication is to give booster dose every 5 years. Okay, and one more important thing is, as per IAP, children are also considered in this high risk group, and they are also considered for pre-exposure prophylaxis. Okay, because we already saw that among the 96%, 45% are children less than 15 years. So they also come under high risk group as per IAP. So till now whatever we saw was all these schedules which we read, was regarding the WHO schedule. Now let us learn, because it will be very confusing for us. First I spoke about the WHO schedule. Now let us see what are the small changes that is present in our Indian schedule, the guidelines taken up by our Indian government, okay, followed by our Indian government. There are few changes, so let's look into those small changes. Whereas WHO presently doesn't recommend observation of the dog or cat, and they just recommend to go ahead and give the full post-exposure prophylaxis, our country still advises this observation period. So observation period of 10 days is valid for dogs and cats only. Only for dogs and cats this 10 days observation period is valid, okay, because in other animals we don't know the process of this disease, okay, fine. So if these two animals, both the dogs and cats, are normal even after 10 days, okay, then we convert this post exposure prophylaxis into pre exposure prophylaxis by skipping the 14 and 28 day vaccine when it comes to the intramuscular regimen, okay. But if it is intradermal route, if the intradermal route is administered, then we go ahead and give the full vaccination series. So this, to simplify it, more than 10 days, dog or cat normal, IM is being followed, IM route is being given, then just 2 doses we give 2 doses and make it as pre-exposure prophylaxis instead of post-exposure prophylaxis, okay. So that is simple, okay. What about the next change? Next change is about the site. So in WHO schedule we read that rabies immunoglobulin is only given at the site of dog bite, correct? And if some extra is left, then we either discard it, or if aseptic technique is followed, we use it for a different patient. But when it comes to the Indian guidelines also tell the same, because there is no additional benefit that was seen on giving the about rabies immunoglobulin to the nearest IM site. But a small change is, if there are multiple bites or if there are any additional small wounds, okay, and the child does not report, and in case of children they do not report all the wounds, okay, in them if any extra amount of rabies immunoglobulin is left, then we go ahead and give it at the nearest IM dose, nearest intramuscular site possible, okay. So that is the change. So to repeat the whole thing, if the rabies immunoglobulin, if some amount is left after infusing it into the wound, routinely it is not indicated to give at the nearest IM site until and unless it is a child or there are any additional small wounds. In them, go ahead and give it at the nearest intramuscular site, okay, fine. Next thing is about the switch over from one brand to other. So it might often happen that a traveler has come into the endemic area, he has received one form of vaccination. Now he gets back to his native, but over there the same brand is not available. In that case, what to do? The recommendation is to give the same brand, but in such unavoidable circumstances, complete the schedule with the other brand, okay. That is the recommendation, okay. Next is about the schedule. So what we read about the post-exposure prophylaxis before was the WHO, but our Indian government still recommends the updated Thai Red Cross regimen, updated Thai Red Cross schedule for intradermal, and the modified SN schedule for the intramuscular site, okay. This is the post-exposure prophylaxis schedule for India, okay. Next, what is the change? What is the small change? Next one to be considered, we saw that in immunodeficiency state, after giving the rabies immunoglobulin and after giving the rabies vaccination, after 10 days we'll have to check for response. The only small change in Indian guidelines is it has to be checked after 14 days, okay. Next change is about the pre-exposure prophylaxis. We saw that in the WHO schedule there are only 2 dosages, but when it comes to our Indian schedule, it is day 0, day 7 and 1 extra on either on day 21 or day 28 if it is IM. The same thing holds true for intradermal also. Okay, day 0, day 7 and day 21 or day 28. And there are no guidelines regarding monoclonal antibody as such in our present guidelines. Still this has not been updated into our present guidelines. Okay, so that's it about rabies vaccination. Have tried to simplify it as much as possible. The initial whatever we read, schedules we read was on WHO and as per the WHO guidelines, and whatever small changes has been recommended by our Indian government as per the recent National Rabies Control Program 2019. I have told it and summarized it in the end. Okay, so that's it, guys.